Thank you, Dr. Shah, and thank you, Dr. Hoag and Sages, for the invitation to speak with you guys today about something I know nothing about. No, I'm just kidding. If you've been doing this for 20 years, you come across leaks in the operating room during biliary-enteric anastomoses, and you have to have a strategy to do that. So my goal today is to just give you some tools for your toolbox when you're in there so you have something to think about. 7 seconds, you said? So as far as what we're talking about for this module or this part of the session, we're looking, and do I have a pointer somewhere? Which is the pointer, do you know? This one here. Oh, good. Thank you. All right, so we're talking about various forms of biliary-enteric anastomosis, maybe at Whipple, a hepatocogeginostomy, or a roux reconstruction for a bile duct injury or a biliary tumor, or even the big kahuna, I would say the Cadillac of operations, which is the biliary anastomosis at the same time as a major hepatectomy, which carries with it some additional concerns. So what I decided to do was break it down into components that made sense to me, so I came up with 4 steps: prevent, assess, improve, and drain. And it's no mistake that they come up to the acronym PAID. And why? Well, we all know that bile leaks, which if you listen to my talk, you won't have to listen to Dr. Hoag's talk because you're going to prevent them all, essentially result in prolonged hospitalization, expensive procedures by IR and GI, readmissions, reoperations. Certainly the patient has lost wages, and with legal concerns, you might have lost wages. Economic impact from bile leak is really no mystery to this group. There's scant data actually on the economic impact of biliary-enteric anastomoses. However, there's extensive data on financial impact of bile duct injury and late repair. And certainly we know that complications after Whipple result in a doubling of cost, especially and including bile leaks in that experience. So if we look at the P in PAID, which is prevent, we have to think about things before we go to the operating room to try to mitigate the factors that might result in a bile leak. So we look at patient factors and disease factors. And the patient factors are obviously health, nutritional status. The size of the patient will matter in this situation, the tissue quality. And then for disease factors, we have to contemplate whether we're approaching benign or malignant disease, and then the location of the disease, whether it's a stricture or a tumor or an injury. So in terms of the size of the patient, I kind of, if anybody has ever played golf, you know that it's a lot easier to hit a ball off the tee than it is to hit it off the green, and then it gets even harder when the ball is in the rough. So when you look at your patient, if your patient is morbidly obese and has a liver that's hanging over, and then you have a high injury or reconstruction you have to do, all of a sudden you're moving from hitting it on the tee to getting down into the deep rough to try to get that bile duct reconstructed. So your leak rate's going to go up. You have to take that into account. Patients with metabolic syndrome and diabetes, patients who are chronic tobacco users, on steroids and other factors like that are going to be at increased risk of having poor tissue quality and a higher risk of leak. This is a study from Germany, from Dresden, published in HPB Surgery, looking at some of the factors that are associated with postoperative bile leaks. So it's a little bit beyond. There really are no data on factors for intraoperative bile leak. But basically, if patients had major liver resection or preoperative chemotherapy and radiation, therefore more cancer cases, you're going to see more bile leaks in the postoperative period. This has already been shown. Basically, type of disease matters. So you have to think about benign and malignant, chemo and radiation, as I mentioned. Location, whether it's distal, hilar, intrahepatic, and then tissue quality. Luminal diameter, certainly it's easier to sew to a nice, thick, dilated duct, just like in the pancreas. Matters in the bile duct as well. Certainly the higher you go in the reconstruction, now you may not be faced with sewing one duct together, but maybe several. And then the wall thickness, as I mentioned. We have some nice tools at our disposal to prevent these bile ducts leaks, and so we have to know our normal anatomy, and this is normal MRCP, but then we can look and see which ducts are going to be involved when in the operating room, because when you don't know that you might have missed a duct in a reconstruction, that's when you see that ominous sign of the of bile that's leaking after you're done with the reconstruction and you think it's time to go home. Certainly, if you have a hilar cholangiocarcinoma and you have a tumor in this location and you can transect the duct over here, then it's going to be a lot easier to reconstruct than if you're transecting the ducts way up into the hilum and going to the intrahepatic ducts, and that's going to have a higher leak rate. So in terms of prevention, we have to think about the larger patients with the increased comorbidities, the small, thin-walled ducts associated with liver resection and after chemotherapy and radiation. That's going to be our population that's going to be at highest risk of having an intraoperative bile leak. So now how do we assess them? Some of this has already been discussed already. So cholangiogram and air test, we can talk a little bit for hepatocholangiostomy. It's much easier to contemplate in partial hepatectomy. The gauze or Raytec test, I call it, the peroxide test are probably the best go-tos and the things that I will use routinely, even for Whipple reconstruction, and they are easily combined. And the last one is spider sense. If it doesn't look right and you just don't feel right about it, then don't get out of the operating room, because that extra hour you might spend revising that duct could have major downstream repercussions for your patient and for yourself. So cholangiogram or air test, really, this to me is really only very feasible if the patient already has an indwelling PTC. So if the PTC is there, you can choose to leave it across the anastomosis, or you can cut it higher and you can leave it within the liver above your anastomosis. In that situation, then you actually can have your circulating nurse inject the PTC itself to look for findings of a leak at your anastomosis, or you can inject air and submerge the anastomosis under saline and look for leaks in that situation. I've only done this a few times, but if you have that ability, it's nice. The Raytec or gauze test, very easy. Just irrigate very clearly, dry the area well, wrap the sponge, wait 5 minutes, go do something else, and then remove it very slowly, and you can see areas that are obvious bile leaks. And then you can decide how you want to repair, revise, whether you put some additional stitches in or whether you take the anastomosis down. Peroxide test, the pictures on the right are actually from a liver resection, more associated with Dr. Ferroni's test, but very similar thing. So following the repair, you may drip half-strength peroxide over the area of concern, in this case the biliary-enteric anastomosis, and let it dwell for about 2 minutes. Don't put too much, let it foam up and just keep an eye on it. Same thing. Give it some time, and then if you see some bile there, then there's something that may show up, just like in this picture, seeing a little spot of bile. There was actually a study done in an Indian journal that showed that the leak rate detection was much higher if you used the peroxide test rather than just saline alone. So now we're on to I, improve. So various things you can do. You can place additional sutures. You can revise the anastomosis. You can do a partial or a complete revision of the anastomosis. There's stenting, and you can leave indwelling or transhepatic stents. And then we shouldn't forget this technique of a Hudson limb, which I'll show a picture of in a moment. So I figured at SAGES I have to show at least one video. So discussion about whether you do an interrupted anastomosis versus a continuous anastomosis. I found one study saying that now continuous anastomosis after a bile duct injury reconstruction is associated with a lower leak rate, and I always thought it was more the interrupted, but let me see if this plays. Yeah. So just using barbed suture and doing hepatocholangiostomy now at the time of a Whipple reconstruction, how things have changed. I'll just move on to the next. When you decide to revise the anastomosis, one of the simplest things that I have done is taken down the front row of the anastomosis, look at the posterior wall. You sometimes don't have to take the whole thing down. If you do, sometimes it's hard to get it back together. Now the tissue's a little bit beat up, and you may have a difficult time reconstructing that. So taking the front wall down, you can reinforce the back wall, sometimes just place some vicryls across the anastomosis, and then redo the front wall. At that same time, you may want to consider then leaving some type of stent, either a biliary stent, or I like these Hobb stents that Dr. Hogue taught me about, and same thing, you can get those in. This is actually in a pancreatic anastomosis, but same concept, you just feed it in on one end, and you can feed it into the other side, in this case, if it was the bile duct. Certainly, if the patient has a PTC in place, you can leave that across the anastomosis. And then I mentioned earlier about a Hudson limb. So for those of you not familiar, the Hudson limb is downstream from the biliary-enteric anastomosis. You can actually suture the jejunum to the abdominal wall. And to make things easier for your radiology colleagues, typically you can suture some, lost it. That'll go back. Yeah. You can use some clips or pacemaker wire, and you can put that right on the side, so that's radio-opaque, so that your radiologist can pierce that area percutaneously in order to get into the limb and not have to go through the liver in case you have a leak or a stricture afterwards. One slide on drains. There's really no data on the question of drain when you identify an intra-operative leak at the biliary-enteric anastomosis, but certainly if you have concern at the end of the case, absolutely leave a drain. There's no good randomized data on this. The question is, again, Dr. Ferroni mentioned the question of whether you do a passive drain or a suction drain. Sometimes we split the difference and leave it on suction overnight and move it to a passive drain the next day. I'm in favor of early removal, post-op day 1. If you see no bile in the drain, take the drain out. And again, I found no clinical trials on this issue. So in summary, we want to use this acronym of PAID, prevent, assess, improve, and drain, so that we don't end up with this, and instead that we get this result. Thank you so much for the opportunity to speak.